Thank you, ma'am. So I think in the next 10 minutes or so, I'll just simplify the practical approach to management, or a practical approach to, I think management will be covered by the speakers coming on after me, to a clinical diagnosis and investigation. So it's more of a clinical oriented talk rather than in the theory of the subject here. Have no financial interest in the mention of anything during the course of my talk here. So when you look at peripheral ulcerative keratitis, so which means the ulcer is situated in the periphery of the cornea. So you have a 360 degrees limbus. So it's there anywhere around the periphery of the cornea, and the word ulcerative means that the epithelium has broken down, and so there is an ulcer which is present, and it can be of any configuration here. Normally when people refer to PUK, the first picture which comes to their mind is it looks like it's a Moran's ulcer. So everything tends to look at or be treated like a Moran's ulcer. So that's a concept which needs to change, and you have to understand that a peripheral ulcer can occur because of several reasons here. So I've just placed the top reasons here. This is not an exhaustive list, but this is the most common things which one might see in anterior segment practice here. So the first will be a marginal keratitis here. So when you do look at these patients in very early stages, the marginal keratitis commonly occurs secondary to or along with a lid pathology, a blepharokeratoconjunctivitis here. And it starts as an immune pathology because of the immune toxins of the staphylococcal species which are colonizing or along the lid margins here. So these tends to be a local immune abscess here. And if this is not treated correctly or recognized correctly, the abscess tends to give way because they are just necrotic tissue, and then forms an ulcerative lesion which can be mistaken for an infectious keratitis or for a Moran's ulcer type of a keratitis. And this commonly would occur on the upper limbus, but it's not an exception. It can occur in any part, commonly the upper or the lower limbus. So that's another common clinical condition when you see an untreated blepharokeratoconjunctivitis with you. Again, you can have simple infectious lesions caused by gram-active, gram-negative, which can occur in the periphery of the cornea. And depend the periphery, if you have a viral lesion which is presenting like similar to a PUK, then you would probably go back and look at if this is an immune-compromised patient here. So these are the patients who tend to have peripheral lesions earlier here. So those are infectious and the herpetic presentations. Flectonelokeratitis or flectonules secondary to severe allergic disease, you usually will have telltale signs in the other parts of the eye, which says that this is an eye which has been predisposed to recurrent or chronic ocular allergy. And when flectonules which are occurring in the periphery break down, they can cause an ulcerative lesion, but this is usually a lesser thing which you would see, and you would find features of frank limbitis and infection which probably leads to the ulceration in such cases. Another common scenario would be in elderly, where you can have peripheral furrow degeneration, senile furrow degenerations, which can mimic peripheral ulcerative keratitis, and Tyrion's marginal degeneration. This is a non-inflammatory lesion and will not have infiltrates and will have associated corneal thinning here. So the first and foremost, when you're looking at a PUK vis-a-vis Moran's ulcer, you would look at the scleral involvement. So whenever you are having a scleral involvement, always you should be alerted that this has an etiology, and probably you're not looking at just a Moran's. And again, the other signs of presence and absence of infiltrates, the lesion being more virulent or less virulent depending upon the morbidity of the lesion. So I'm just going to run you through the important differentiating features in systemic examinations which can point you towards a PUK which is occurring secondary to a systemic, like a saddle nose deformity and auricle pinnae. You can have oral ulcers, mucosal ulcers, butterfly rash of the face. These are all telltale signs that the patient is having an SLE or a relapsing polychondritis. Systemic sclerosis features like telangiectasia of the vessels and facial vessels, rhinophyma. Vasculitis will have other systemic features usually associated, and the pertinent pertinent features for giant cell arteritis is temporal artery tenderness, Raynaud's phenomenon, in systemic sclerosis, SLE, Sjogren's here, subcutaneous nodules if you look at rheumatoid arthritis. So most commonly you will find PUKs in rheumatoid arthritis patients secondary to the dry eye disease and the immune pathology and the disease of the ulcer here. Similarly for GPAs and for polyarthritis nodosa, relapsing chondritis, I think I would refer you to go back and look at the systemic features which could be present in these patients. A quick run through of what you need to do when you're looking at a PUK which is associated with a systemic disease here. The first and foremost is simple blood investigations for the patient. You would look at C-reactive proteins, the nephrology investigations, immunological investigations will include CANCA, PANCA here, anti-nuclear antibody titers, rheumatoid factor if you're looking at a rheumatoid-induced pathology, anti-complement factors here, ACE, and specific tests for any suspected infections like syphilis, tuberculosis, sarcoidosis, and imaging pertaining to this suspected infection needs to be done. This is in a nutshell the important ones which you would probably place to, and if you pinpoint something which is there, then you would probably coordinate with your treating physician here to look at more immunologic investigations for these patients. Murren's is a diagnosis of exclusion, and when you do not have any point and you are having an ulcer, and usually Murren's presentation is very characteristic, we have overhanging edge, and it could have a progression both circumferentially and laterally here, and can involve, when untreated, the entire, and even with treatment, can involve the entire circumference and might necessitate interventions in these cases. You do have a classification of a type 1, type 2, and type 3, depending upon whether they are unilateral, they are bilateral, and whether they are virulent or they are not so virulently progressive, and about the age group and racial differences here. So I think sometimes this does not conform to the pattern, and you would find something which is supposed to be benign being more malignant, and vice versa itself. But usually the clinical feature is quite confounding for these patients here. Just run you through quick examples before I stop here. Here, this is how you're finding a large peripheral gutter which is also extending for quite a significant region in this region, and what you need to watch is the thinning, because this might perforate in cases of Murren's here, and that would warrant an intervention. This is a case of blepharokeratoconjunctivitis where you could see the lid is obviously infected with severe morbidity here, and you have lesions which have started developing here. So this you would probably need to treat with steroids rather than bombarding them with fortified antibiotics, because that will only lead to the increase in the immune abscess. A patient with syphilitic peripheral ulcerative keratitis, you see the rest of the cornea again has got involved, and you have intense anterior chamber inflammation as well in these cases here. Again, if the peripheral ulcerative keratitis has been left untreated for long, it cannot withstand, the thinning cannot withstand the raised intraocular pressure, or progressive necrosis by secondary infection can lead to perforations such as this, and you will have to intervene for management in these patients here. Small peripheral lesions can heal well, and remember, whenever there's an associated scleral thinning, there is a pseudopterygium formation, because the limbal stem cells have also been affected here, and the neighboring conjunctiva tends to grow over and cause the healing, and also compensate for the corneal thinning here. This is a picture of the Tyrion's marginal degeneration here, and again you look, it mimics an ulcerative lesion, but you would have epithelium over this here. It's usually a quiet eye here, associated thinning, and you would have this lucid interval, and you also have the lipid pigmentation, which are all characteristic features. So a quick run through on an algorithmic approach. History and clinical examination will remain the key to decide what are the causative reasons for what are the reasons why this particular PUK is occurring here. Apart, once you've examined and you've come to a reasonable conclusion, your investigative modalities will depend upon what is your conclusion, or what is the empirical diagnosis. Is it infectious? Is it immune? Is it allergic? Is it a peripheral degeneration? Or is it associated with systemic causes? So you'll have to learn to divide whether it's an ocular or a systemic disease-related presentation in the eye here. And you'll have to differentiate important and immune is blepharokeratoconjunctivitis and Murans. Your basic workup, again, remember corneal scraping, if you find an infected component, is always mandatory because you need to rule out infection before you take on. Basic workup of hematology and the related investigations here. Immunological workup for these patients, test specific for the particular infection which you are suspecting here, and imaging modalities pertaining to that incision. So you don't need to run a battery of tests, but run what is pertinent for your particular empirical diagnosis for the patient here. I think I'll stop here, and thank you for your patient listening, and thank you, ma'am, for the opportunity to be part of this.
Thank